About 20% of patients do go on to do additional procedures, and that would be fat grafting. Typically, I would say these are patients who really had no breast tissue to begin with, or so little that the breast still looks somewhat deformed. Sometimes there is asymmetry, which is to say that the patient always had a slightly bigger one breast versus the other, so that when we do all these techniques, one of the breasts looks really good, and the other one is a little bit deficient, maybe a little bit flatter in the upper pole, a little bit tighter in the cleavage area. So those are patients that would opt for fat grafting. Typically, we would wait about 6 months until we do fat grafting. So it'll be a secondary additional procedure. And that just involves basically going under anesthesia again to just get liposuction from an area that the patient already describes they have a problem with, an area patient doesn't like. And then we use that fat in order to augment either the deficient breast or both breasts, depending on what we're planning.
Where are the places? Because I don't know, is all fat created equal, or where are the places that give you a good kind of fat to transfer into the breast?
Yeah, so classically, the places that are best that are described is the abdomen and the flanks, and to some extent the medial thighs, the inner thighs, which most patients have a little bit of fat in that area. Even the very thin patients have a little bit of fat in that area. But ultimately, it's what the patient's preference also is. We take that into consideration. Whenever I do fat grafting, I consider that as a cosmetic opportunity as well. I do not just consider the fat graft, the donor site, as a donor site. I consider it as an opportunity to give a patient a nice liposculpture result in that area.